For me, the other big variable, which we have more data on now than we did a few months ago, but still not a lot, is the question of sequencing therapies. We've talked about high response rates, high depth of response, but nobody really has dared to use the word cure with the current targeted therapies and their current regimens that we use. And so we're thinking about a long game for patients, and I'm always trying to focus as well on what information I have from prospective studies to really support what comes next. And that's always a very, very important question when we're trying to decide, do we start with venetoclax and go to ibrutinib? Do we start with ibrutinib or another BTK and then go to venetoclax? And the data are limited at this point, so there is a lot of extrapolation in order to try to support that decision. Any comment on prospective studies that have been done to support sequencing?
I don't believe that we have a lot of prospective data to support sequencing of one agent after another. I think all the data are predominantly from retrospective studies, which are very important because, like you mentioned, patients will ask, okay, if my disease stops responding to venetoclax, or if it recurs after venetoclax is reintroduced, is there any efficacy for the BTK inhibitor? And I think at this ASH we saw data from at least 3 different data sets, including a very large study that you presented at ASH, where it seems that there is a very good proportion of patients who will respond to ibrutinib if venetoclax stops working. And I think that data is reassuring to many of us as physicians who are counseling our patients and to patients themselves, as they know that it would be okay to go with a time-limited therapy of venetoclax, knowing that ibrutinib will be available should disease recur after a period of time.
And we'll go ahead. Sorry.
Yeah, there was a prospective phase 2 study of venetoclax to be used for a patient who has progressed after prior
You're reading my mind. That's what I was just
B-cell
about to ask you
receptor
about.
pathway inhibitors such as ibrutinib or PI3 kinase inhibitors. So that's a single-arm study. So in that study, patients who failed the prior either BTK inhibitor or PI3 kinase inhibitor can still have a pretty high response rate to venetoclax single agent. So I think in that direction, actually, there are probably more patients who are treated in that fashion because ibrutinib was approved several years ahead of time. But now that we have venetoclax upfront available, so the real question is, would patient respond well to the B-cell receptor pathway inhibitor such as BTK inhibitor or PI3 kinase inhibitor after venetoclax being used upfront? As Samir mentioned, that your retrospective analysis actually probably gave the most data on the efficacy. Do you want to touch on that?
We presented a large number of patients who discontinued venetoclax, and there was a small subset, about 44 patients, who had never seen ibrutinib before but went on to receive it after venetoclax, and it seemed to be quite active. And Jennifer Brown had a similar experience with, I think, 27 or 28 patients who went into that same sequence, and she did show activity. You mentioned the phase 2 trial looking at venetoclax after ibrutinib or idelalisib. From what I remember, there was a fair number of patients on that trial who were actually intolerant of one or both agents. So I was thinking maybe that's a good segue to talk about the case that I brought, which is a patient who had some intolerance issues. So why don't we switch gears to that case?